So I'm just going to discuss about the provision of HLA selected platelets. So Amy has gone through some of the case studies, and I will touch upon those just a little bit, just on the points of what H&I really do from that point. So I'm going to go through just the basics of what really HLA is, and I'm sure most of you would know, but HLA, it just simply stands for human leukocyte antigens, and it is the MHC, which is the major histocompatibility complex within humans, and it is located on the short arm of chromosome 6. And HLA genes are highly polymorphic, which means that you will find one or more alleles expressed in the population, and that's a good thing and also a bad thing, because a good thing is that this is why we can provide transplantations and transfusions, but the bad thing is that it also causes a lot of complications, which I'll touch upon in the next few slides. So HLA is subdivided into two main classical regions. So you've got HLA class 1, which is HLA A, B, and C, and these are expressed on the surface of almost all nucleated cells. And for this audience, in particularly on platelets, which is why HLA class 1 is more important, and that's what we really test for when requests are made to NHSBT. Class 2 is the second region, and this comprises of HLA-DR, DQ, and DP, and these are expressed mainly on B lymphocytes, antigen-presenting cells, so you've got monocytes, macrophages, and dendritic cells, but also activated T lymphocytes as well. But these are more important mainly in transplantation rather than transfusions. And HLA genes are inherited as haplotypes, so you inherit them from one from each parent, and they're codominantly expressed, so very similar to the ABO and rhesus system, and therefore they are so clinically important in transplantation and transfusions. So next slide, please. So how does HLA sensitization really occur? And it really occurs through the exposure to non-self HLA molecules. And this really could be through transfusions, but also through pregnancies or foreign tissues from pregnancy and transplantation. And the question is, are these HLA antibodies harmful? And the simple answer is yes, they are. So patients who become sensitized to these HLA antibodies in terms of transplantation, they face longer waiting time for an organ. And statistics say they highly sensitized patients can wait up to 3 years or more for an organ that is suitable for the patient. And in terms of graft rejection, sometimes transplants do occur across these HLA antibodies, very low level antibodies, but graft rejection can occur, and repeated episodes of graft rejection can lead to graft failure, and the patient would then require a second transplant, which again is an added complication for any future transplants. But in the field of transfusion, HLA antibodies can destroy incompatible platelets, and this is what can then lead to platelet refractoriness in terms of immune causes. So next slide, please. So Amy has gone through this slide, so I'm not going to dwell on it too much. But again, you've got a non-immune causes and immune causes. And from a H&I point of view, we really want to be looking at the immune causes. The non-immune causes should have been ruled out by the hospitals before samples are being sent to the laboratory. And the main cause of refractoriness that we see in our patients is really due to HLA antibodies, and in this case, HLA A, B, and C, which is what we will test for. In rare occasions, and it's usually less than 1% of patients will develop HPA antibodies. So you can see how rare HPA antibodies are, and even rare cases, ABO. And I think for us, we've only had 2 patients who has been refractory to ABO, and 1 patient who's actually been refractory to all 3 immune causes. And we supply platelets to over 200 patients, so you can see how rare it is. The HLA seems to be our biggest cause of immune refractoriness. Next slide, please. So really just wanted to add this in. What is the role of H&I laboratory? So our main role is to detect HLA antibody antibodies in these patient samples. So we support transfusion services, but also the transplant services as well, and that is our main role. And we will then provide advice on patient management through transfusion and transplantation as well. If antibodies are detected, we then need to identify what HLA antibodies there are. We also do HLA typing for the patients and donors, both in transfusion and transplantation. And in transfusion, this is particularly important because without having pre-tested our donors for HLA and HPA, we wouldn't able to support our patients with HLA selected platelets. And then, of course, it's for us to then supply and issue these products to the hospital and the patients. And the next important part really is to document the post-transfusion increment counts, because this will allow us to advise on how to better manage the patient, in particular if they're not incrementing to their HLA platelets. We would then need to advise whether we need to send them for HPA testing or whether other things need to be looked at as well. Next slide. Again, I've just put this in for reference really, and I apologize that it is very small, but if you need to, if anybody wants to have a look at this, just email me and I can send you the reference over. But this is just an algorithm that we use to assess what testing needs to be done. So if the patient has been receiving HLA support, but they're still not incrementing, then it just gives us and other healthcare professions advice as to what next approach to take. Next slide. So what we're really interested in is how do we test for these HLA antibodies? So when you suspect platelet refractoriness, you send NHSBT samples for testing. Within NHSBT, we have 6 H&I laboratories, and each H&I laboratories will be affiliated with those hospitals. So you send your samples to them. We would expect a 6 ml EDTA sample and a 6 ml clotted sample to be sent to us. EDTA is particularly important when you send a new refractory case over, because without an EDTA, we cannot do a HLA typing. Currently, we perform this through next generation sequencing. So this is probably one of the most advanced technology that we have in our laboratory, but it's a complicated process, and therefore to generate the results takes much longer. So currently we have a lead time of 9 working days to turn a results over. Then some HLA antibody screening. It's a clotted sample. We use a Luminex bead-based technology, and I will go through that a little bit in the next slide. And currently, this takes 9 working days. However, we can turn results around much quicker because it is, I wouldn't say a simpler test, but it is a much more simpler test than next generation sequencing. So we can have results within 5 working days, really. But this 9 working days that just allows extra assessments to be made because there are inherent problems with the testing kit. Next slide. So how do we test? So the method might be simple, but as I said, there are inherent problems with the kits. So we have 2 main kits that we use in our H&I lab. So there's a screening kit that we use, and this just allows us a basic assessment of whether there is HLA antibodies present or not. If there are antibodies present, we will then use a more specialized kit known as single antigen kit. And this is specific to identify what HLA antibodies are present in the patient's serum. So the test itself is very simple. So the kits that we use have microscopic beads, and these microscopic beads are color coded and coated with HLA antigens on them. These beads are incubated with the patient samples. So if there is any antibodies present, they will bind. We will then we'll do a washing step to remove any unbound, and then we will add a marker, basically, which is in the form of a fluorescent conjugate. And we will use an IgG conjugate because it's more clinically relevant. We will then do a final step, and then we'll place this into a what we call a lab screen flow and analyzer. And it's the principle is very similar to a flow cytometry, where the laser, it has two main lasers, and these, as the samples pass through, the lasers will be able to detect what bead and what antibody has been bound, and then the other laser will be able to detect at what quantity those antibodies have been bound at. And we will then use a software to analyze that data, which will then result in a mean fluorescent intensity. We have a cutoff, and all laboratories will have their own cutoff, but usually the cutoff are usually about 1,000 to 1,500 MFI. Anything above that means there is a positive antibody, which will cause destruction of those platelets, and anything below we will report as negative. So if we're found to have patient samples are found to have antibodies, then we will report that to the hospital for immediate transfusion provision, and then we will support them with HLA selected platelets. So if we go to the next slide. So provision of HLA selected platelets will then be based on a HLA type of the patient, which we should have. And if we don't, we will have HLA antibody specificities there. So we can provide platelets based on HLA antibody results alone until the HLA typing is available. If HPA testing has been performed and we have found a HPA antibody, then we will also need to consider that as well. And actually, HPA will take priority over HLA at that point. Other factors that we may have to consider also is CMV and RH status as well. CMV, even the SABTO guidelines do suggest that it's not required. We do have requests for CMV. We do need to just bear in mind that when you do have CMV requests, this really does reduce what available donors we have, and it does compromise your HLA. And if you're asking for HLA selected platelets, HLA should really be your priority. RH status, we will provide RH platelets to patients who are women of childbearing age and pediatrics, or if the patient has been worked up for a transplant and their donor is RH. Next slide. So how do we actually do this matching? So I've just given a quick example of how matching and selection process is done. And this will have thousands of donors. So currently there are up to 12,000 donors that are HLA and HPA typed. And what we do, those 12,000 donors will be on our database system. So will the patient's HLA type. And what the algorithm that we have set up for individual patients is that it will look at the patient's HLA type and compare that to all the available donors' HLA type. So it will eliminate any donors that do not match the patient's HLA type. We can then also add into the algorithm what antibodies the patient has. So in this case, patient has very limited amount of antibodies and should be relatively easy to match for. This will then reduce that list down further. So from 12,000, it may go down to 500, and then we can then keep adding any extra criteria in there, and it will reduce our donor pool. So the more criteria you add, the more donor pool that goes down, and this could then reduce your match grade. So from this table, you can see we've got 5 different units and 5 different types of HLA. The first unit is your perfect match grade that we would consider as an A match grade. So it's complete match to the patient and donor. And these are the types of donors that we're really looking for. But these are very rare sometimes, and therefore we have to then drop down to the next available donor. And this will be known as a B1 match grade. B1 match grade is where there is a single HLA mismatch between the patient and donor. And where possible, we will try and make sure that that mismatch is either a negative antibody or that mismatch is closely linked to the patient's HLA type. Now, this just goes with the years of experience that I know that the A24 from the patient's HLA type and the A23 it shares the same epitope, so that I know that the patient should do well with that. And then the next three, 4, and 5 donations, which are 2 mismatches, 3 mismatches, and 4 mismatches. And these we would term anything from B1 to B4, we actually term as selected platelets, and only the A match grade is a matched platelet. So that's HLA matched platelet, and B1 to B4 is HLA selected platelets. We know from data that better responses are usually from A to B1 compared to B2 to B4, and that's what we're really aiming for. So when we do request for platelets, bear in mind there's a reason why we ask for 24 hours notice, and that's so that we can get you the best platelets, and that's where we're aiming at A and B1, because we know that better responses occur from those. Next slide. So this is just touching upon a couple of case studies that Amy presented. So I'm not going to dwell on this much. She's already gone through all of this. But what I just wanted to really highlight from this case study is the HLA type. Fortunately, this patient did respond very well to the HLA matched platelets despite the patient's HLA type. Now, I can tell you that the A31, A33 of this patient's HLA type is not common within our donor population, which means it becomes extremely difficult to provide platelets for this patient. The added benefit for this patient was that her antibody profile was only an A3 compared to the next case study, which was highly sensitized, and the patient had no HPA antibodies, which means it was slightly easier to provide platelets for. So for next slide, please. So apologies, I know it's a complicated and a busy slide, but it's just to really highlight how we would do this. So we ideal increment counts we want is greater than 10. The first 2 units were an ABO match unit, so these were not HLA. And this I just wanted to add in there to show you how poor the increment counts were. And Amy had shown this in her graphs as well. The next, and I've just picked out a few of the donations that were given to this patient. She did have a total of 101 HLA selected platelets, which only 59 out of those 101 we had received increments back for. 34 of those 101 units were B1 match, and 67 of those were B2 to B4 match grade. So you can see that the match grades were relatively good, even that the match grades were from B1 to B2. So in this case, it didn't really make as much difference in terms of the units that she got as a B1 or a B2 match grade. She actually responded well to these. And some patients do respond really well to some and some don't. And we really don't know reasons why this happens. So I'll go on to case study 2. Next slide, thank you. So again, I won't really dwell on this too much, but it's patient's HLA type. So 24, which is a homozygote for A locus, B51, B54. It's not too bad. It's not the perfect ideal HLA type that we would like, but we should able to provide some platelets. But the added complication here really is the multiple HLA antibodies this patient has, and these unfortunately are the kind of patients that we really do dread, because those patients who have multiple HLA antibodies where they do not have a large window of platelets that we can give to them, it just makes it really difficult for provision. And the patient had HPA antibody, and unfortunately in this case, patient had 2 HPAs, which is not ideal, but thankfully there were also kind of the common HPA antibodies that you find in our donor population, so we could provide platelets with HPA. So next slide. So again, it's just really what Amy has said is that her ABO match platelets were poor. She then received HLA only match platelets. So the first two, unfortunately, the only ones that she had were HLA match, but we didn't get any increments back for them. So I can't really show you how well she did. Um, and then the next, I guess the next 4 units that she'd received were HLA and HPA, and she responded really well to those to those products. And this patient, as Amy said, received lots and lots of HLA selected platelets. She was issued over 128 units of HLA selected platelets, which only 76 of those units we actually got a return of increments back. So again, the importance of returning increment counts back is vital because it allows us to assess how the patient is doing with those individual platelets that we send to you, because we then can tailor how we can best support your patient and what we can provide. There may be an antigen that we have to completely avoid because that one particular HLA antigen is destroying the platelets, or at that point we can also advise whether the patient actually needs to be tested for HPA antibodies. But not only that, we can also check whether the patient requires more HLA antibody testing. And we do expect patients to be tested every 3 months because the transfusion HLA antibodies do vary considerably. They come and go, they're not constant. And so we do need to assess where they are at in those 3 months. And I think that's it. Thank you for listening. If you've got any questions.
Thank you both. It's absolutely fantastic.